Hello, good evening, everybody. First of all, at the onset, I would like to congratulate the ASG Academic Cell for conducting another amazing masterclass with such esteemed speakers and panelists. Uh, these masterclass, as such, are nothing short of pure gold when it comes to the learnings that we take home from them. Before this, we've had multiple other lectures and classes. Uh, the speakers were both national as well as international. So some of our prominent international speakers that we've had before this are like Dr. Sengul Ozdek, Professor Remzi, Dr. Barbara Parolini, Dr. Zofia Anna Navroka, Dr. Ahmed Salam, Dr. Neto Rosaletti, Dr. Rajiv Muni, and Dr. Ulrich Spandau, with many more to come. Some of the amazing Indian stalwarts that we've had who've presented or spoken are Dr. Pramod S. Bende sir, Dr. Professor J.S. Titial sir, Dr. Mahesh Shanmugam sir, and Dr. Avinash Patange sir. I would also like to inform everybody about our YouTube channel, which is called as the ASG Academy. In this channel, we've had all the previous lectures and masterclasses that were taken by both international as well as national speakers are already there. Plus, amazing teaching videos by our own consultants from ASG are also there. So I would request everybody to please go and check it out and subscribe for further future content. Now, for today, continuing the legacy of excellence, we have Dr. Parveen Sen ma'am, who will be presenting on idiopathic polypoidal choroidal vasculopathy. As such, our speakers or the panelists don't need any introduction, but still I would request Dr. Shishir to please introduce them formally. Dr. Shishir, please.
Unmute.
Yeah, thank you, Dr. Devashish. I'm grateful to be getting the opportunity to talk about our esteemed speakers for our class today evening. Today, the speaker for our lecture on polypoidal choroidal vasculopathy, Dr. Parveen Sen ma'am, is a senior VR surgeon at Dr. Agarwal's Eye Hospital, former senior consultant at Shankar Netralaya, Chennai. She has over hundreds of publications, multiple chapters published in different textbooks. She's been invited for several talks. She's a reviewer for national and international journals for areas of interest of work being ROP, retinal imaging, pediatric retinal surgery, electrodiagnostics, and hereditary disorders of the retina. So Dr. Parveen Sen ma'am will be giving us a talk on IPCV and how to deal with things, how differently can we go about diagnosing and managing IPCV. We'll look forward to the discussion, ma'am. Our panelists for tonight are Dr. Ashish Sharma, sir. He's a senior vitreoretinal consultant at Lotus Eye Hospital, Coimbatore. He is a clinical retina and research fellow from the University of California. He's an ex-faculty of Ali Prasad, Hyderabad. He's been awarded the International Ophthalmologist Education Award by AAO and Ophthalmic Hero of India by AIOS. He has had several articles in peer-reviewed journals along with multiple book chapters published. He is on the reviewing and editorial board of high-impact ophthalmology journals. He is listed in the Stanford top research list in ophthalmology in India in 2021. We welcome Dr. Ashish Sharma, sir. We get to know about a lot of his work on biosimilars often. Our next panelist for tonight is Dr. Thirumalesh. He's a senior VR consultant at Narayan Netralaya. He's completed his medical education from BMC Bangalore and his graduation and SRship from the prestigious AIMS. He has several publications in high-impact in-text journals with multiple book chapters published. He has presented at various national and international conferences with various awards to his credit. His current area of interest is molecular biomarkers in ARMD and diabetic retinopathy. Our third panelist for the night is Dr. Debdulal sir. He's a senior VR consultant at Disha Hospital, Kolkata. He's had a fellowship in VR from SN Chennai. His training in ROP is from the Orbis International. He's an international observership. He's had an international observership in VR from Bascom Palmer Eye Institute, USA. He's a reviewer of different national and international journals. He's had several publications in peer-reviewed journals. He's a principal investigator in many trials. I welcome all our panelists and our speaker, Dr. Parveen Sen, ma'am, and would not be wasting any more time. And we start with our talk for the night. Dr. Parveen Sen, ma'am, please.
So thank you so much, Dr. Shishir, for the kind introduction, and good evening to everyone. I'll be sharing my slides. So to be honest with you, I am in this field of retina for nearly 25 years, more than 2 decades now. And it's not the first time that I'm giving this talk on PCV. I have given this talk, but every time I have to give this talk, I really have to update it. Because this is one field which is evolving, new knowledge, new information is coming thanks to retinal imaging. And thanks to Dr. Atul for giving me this opportunity to update myself on the diagnosis and treatment of PCV. So I'll share with you all that I have learned, and hope that you will help me fill in the gaps in my knowledge, as well as we will fill the gaps in our collective knowledge as well. So with that, PCV is not as rare as we think it is. In fact, it is considered to be a subtype of neovascular AMD. Earlier, it was thought to be more common in the Asian population and not at all in the Western areas. But now it is known that it is present in almost all ethnicities, but definitely in Southern Asia, it is more common, and almost 50% of the patients may have an underlying PCV phenotype in cases which are thought to be neovascular AMD. So we know this is a part of the pachychoroid disease spectrum, and the other disease entities which form a part of this are CSC and focal choroidal excavation, and PNV, and peripapillary pachychoroid syndrome. Pachydrusen is a recent addition. What is pachychoroid? Where the normal thickness is about 190 to 350 micron of the subfoveal choroidal thickness. More than 300 micron is considered abnormal, and dilatation, especially in the hallux layer, is considered pathogenic. And this is an extreme example of a very diffuse and thick pachychoroid, though it may not always be so diffuse. Here you can see it's a focal kind of choroidal vessel dilatation under the area of choroidal hyperpermeability. And pachyvessels on OCT appear as thickened vessels, whereas in ICG they appear as large vessels which do not taper towards the end as a normal ICG vessels do, and they kind of leak a little more as well. So what is more important than absolute thickness is the morphology of the choroid. So it is thickening of the hallux layer, which in turn pushes the choriocapillaris and the sacculus layer and causes thinning of the choriocapillaris. So ultra wide field ICGA has added to our knowledge, and we have now understand that these thickened choroidal veins are nothing but branches of vortex veins. And this dilatation happens because of there is a blood flow stasis. This blood flow stasis is secondary to vortex vein congestion. And because of this congestion, there is obliteration of the normal watershed zone, which extends almost up to the posterior bone. So if you don't have a wide field ICG, you can still make out this on an OCT, especially on the end-pass OCT. There is an option of seeing end-pass images on most of the OCTs. And if you open that and see, this is the normal watershed zone, which is present in the superior and inferior part halves of the retina. If you see a patient with PCV, this gets obliterated. And this is because of the dilated ampulla of the vortex vein in the periphery and the back congestion of these choroidal veins, which can be seen up to the fovea. And it is now known that if there is anastomosis in the horizontal meridian, this is what we usually see in PCV and CSC, and a vertical meridian anastomosis leads to the peripapillary pachychoroid syndrome. And PCV has significantly higher anastomosis, maybe because of high kind of ischemia, and maybe because of the high ischemia, it gives rise to new vessel formation as well. So there is an underlying ischemia because of the dilatation of Haller's vessel, which push the choriocapillaries, and that causes ischemia and neovascularization. So to confuse things more, all that we said was that it is a part of the pachychoroid disease spectrum, but now we know that some kind of PCV with polyps can be present in a non-pachychoroid setting as well. So this kind of PCV or polyps which are seen without a thickened choroid are known to be much older age group. They have more of AMB features like presence of drusen, and they show a good response to anti-VEGF therapy. So when I had started learning about PCV, we were taught that if you see CNVMs in the absence of drusen, you have to think of PCV. But now we know that you could have drusen and thin choroid as well, and still have polypoidal lesions, which is why now it is understood to be a part of our AMD spectrum, where you have aneurysmal dilatations and maybe has a genetic predisposition, wherein the ARMS2 or HTRA1 risk alleles are more associated with the drusen-driven PCV. Enough of pathophysiology. Coming to the clinical spectrum, we know that it can present in many ways, and ranging from asymptomatic polyps to a massive subretinal bleed. And the original diagnostic criteria from Everest was the presence of polyps appearing within the first 6 minutes of ICGA in association with deviant or pulsation of the polyps or nodular appearance. And in a nutshell, the hallmark is this. There are two components. One is the branching neovascular network, which is seen here, along with the polyps. This is how it looks on ICG. This is how it appears clinically, where there is orange red nodule. And this is how it is well picked up on OCT. So you can see this is a simultaneous OCT with ICG, which is available in the Heidelberg. And this is the polypoidal lesion, which gives rise to this notched PAD. And this is the branching vascular network, which is present kind of here. This giving rise to a double layer sign. So when you see this as a combination of a double layer sign and a polypoidal lesion, so the first thing comes to your mind is a PCV. And this is very well seen on ICG, but the problem with ICG, we all know, is the high cost and not easy availability, which is there in all situations. So can we rely upon OCT to give us a diagnosis and management of PCV, which is the highlight of today's talk? So you can see characteristic features of PCV and OCT, this thumbnail-like PED and this double layer sign. And if you see something like a notched hemorrhagic PED, why do I say it is hemorrhagic? Because it's the total back shadowing of the structures below. You don't see this at all. So to show you this comparison, this is the hemorrhagic component where there is blood under the pigment epithelial detachment. You can see that you don't see the underlying choroidal, there is shadowing, but if there is a serous PED, you are able to see this underlying structures. So this is how you will differentiate a hemorrhagic PED from a serous PED. And if you see this double layer sign or a thumb-like multi-peaked PEDs, and you see this hyperechoic area, which is below this double layer sign, this usually shows the presence of a growth of the neovascular component within this pigment epithelial detachment. And this we know that the notched PED is all a hallmark of PCV. If you look very carefully in this sub-PED space, if you see this kind of a hyperreflective lumen, this is a classic example of a polyp sitting right under this PED. And on treatment or following therapy, it may collapse and it will become like this. It becomes hyperdense. So this is a collapsed polyp, and this is reflective lumen is an active leaking polyp. So this is the diagnostic thing of PCV. Even response to therapy can be seen on OCT. And now comparing to OCT and ICG, we know that OCT is non-invasive, more easily available, and gives you a depth resolved, reliable information. So OCT can be used in the various forms of retinal conditions, including PCV. In fact, OCT has now become the new gold standard. And based on OCT, the consensus nomenclature now is that the PCV is a variant of type 1 neovascularization consisting of polypoidal lesions and branching neovascular network BNN is the newer term instead of BVN. PL is the term instead of polyps. We are calling them polypoidal lesions. So uniformity of nomenclature so that we all understand what we are talking of when we talk of these lesions. And 3 identified major criteria by this Asia Pacific Society of Imaging. They said sharp peaked PEDs and the sub-RP ring-like lesion, which I just showed you in the last 2 slides. These form the major criteria. Third major criteria they said was the ENFAS OCT complex RP lesion. So this is what you see. This kind of a picture you will see in this IR image or a ENFAS OCT image. This OCT image is always present along with the B-scan OCT. If you look carefully, this will be present. And if you see this kind of elevated RP complex, this is highly suggestive of a PCV. So this, a sharp peaked PED, a sub-RP ring-like lesion, and an ENFAS OCT RP complex elevation, these are the major criteria for diagnosis of PCV based only on OCT. You see, there are some multiple minor criteria like multi-lobe PED, double layer sign. Thick choroid is a minor criteria because now we know that PCV can be present even with normal or thin choroids. Orange nodule and extensive subretinal hemorrhage form other minor criteria. So these are the other minor criteria: multi-lobe PED, double layer sign, then orange nodule here, subretinal hemorrhages, and pachychoroid. So the previous major and minor criteria were for treatment naive eyes. Now we know in the era of anti-VEGF therapy, we are almost treating all neovascular components with anti-VEGF. So is it that, how do we recognize it after we have given anti-VEGF and we know that it is not responding? Now we want to know, is it PCV? And do I need to change my therapy? So do I again have to go for ICG? No. So they have come up with non-ICGA criteria for suboptimal response, and then you diagnose whether it's PCV or not. And these criteria is that after you have given 3 loading doses, then if you go back and analyze your OCT and you see that in spite of 3 loading doses, there is not adequate response and they have presence of sharp peaked PEDs, hyperreflective sub-RPs, ring, and an orange nodule on fundus photography, then think of PCV. The ENFAS RP elevation, which was considered a major criteria in treatment naive eyes, did not find a space here as a major criteria because once the eye has got anti-VEGF therapy, the SRF at least definitely comes down to some extent. So there, some response will be there. So this may not be very easily visible in patients who do not respond to anti-VEGF therapy, and now you are thinking to detect PCV. In those patients, you will have to probably think of these 3 criteria to think of PCV. On OCTA, does OCTA add to our information? So yes, in some cases, it may even be superior to ICGA, especially when detecting BNN. So BNN, now we know, it's almost like the type 1 neovascular component that we have in patients with AMD. And so these are very easily picked up. Almost in 100% of the cases. Polyps are more difficult to detect on OCTA, and the reason being that increased height of polyp, there is increased fibrin and exudation, and this may hamper visualization of the polyps. Pulsatile polyps, so that the flow is slow, that is why you are not able to visualize the polyps. Then presence of overlying subretinal hemorrhage may again cover the polyps, and lot of segmentation errors because of high PEDs which are associated with PCV may make detection of the polyps again very difficult. So where BVN has been seen to almost be present in 100% of cases, polyp detection rate is being as low as 17% to 42%. And with this, I show you a classic example. This is what I had shown in the structural B scan. On a structural B scan, you can see this is the double layer sign, which is formed by the growth of the neovascular component between the RPE, which gets elevated from the underlying Brooks membrane, because the growth of the neovascular component is between these 2 hyper-reflective layers. So separation of these 2 layers is seen as a double layer sign. And this is the place where the neovascular component sits. And this is beautifully seen on an OCTA. And since there is not much of hemorrhage here, you can see that a beautiful network is seen here on a 6x6 OCTA scan. And this is the same patient, 3x3 scan. You can even see this network more beautifully. You see this thumb-shaped elevation. You see this is hemorrhagic. There is shadowing of the underlying RPE. And you see this well-defined circular lesion. This is a polyp here. So there may be some few adjacent polyps also. On these far away spaces are increased choriocapillaries flow deficit areas, which are again because of the presence of hemostasis in the thickened choroidal vessels. Together with the CCFT, this polyp-like structure with the presence of this typical type 1 CNV, diagnosis is very clear even on an OCTA that this is PCV that we are dealing at. And this can be even better seen on a swept source OCTA, which has deeper penetration because of a longer wavelength. And you can see the polyps very nicely. In fact, this article from JAMA, the authors mentioned that there may be a tangle of new vascular component within these polyps as well. And they may not just be dilated pouches, but we still have to define that further. Huang et al. Have even talked of the various morphology of BNN. We call it as a trunk pattern, glomeruli stick pattern. Why I'm talking of this here is that it has a prognostic significance. The trunk pattern is almost like a typical type 1 neovascular membrane of AMD. It is associated with drusen. It is thin choroid. So this acts more like an AMD. Response to anti-VEGF is good. So vis-a-vis a glomeruli pattern, the type 2 and type 3, which are associated with the thicker choroids, higher recurrence rates, and this behaves more like a polypoidal choroidal vasculopathy. Response to anti-VEGF is not good, and usually you may need to have longer treatment or add photodynamic therapy. So this is what we will talk of now. Treatment. Asymptomatic polyps. So the patient may have polyps without SRF or exudation. You do not do anything to this. This needs no treatment, just follow up. And this is extrafoveal polyp where the macular area is spared. Here you must make an attempt to do an ICG to look at the polypoidal lesion until unless we get wide field OCT or OCTA as well. Till now, we don't have that, which can identify polyps here. So we can only use a wide field ICG to look at these polypoidal lesions. Important is that you can treat them with a simple thermal laser and nip the evil in the bud. So here, ICG may still be useful. Thermal laser, this we published some time ago, can also be done in some kinds of macular PCVs where the fluid and the hemorrhage is in the subfoveal space, but the polyps are actually away. So if you treat these polyps with thermal laser, you can still have a good response. This is another one. You can see this is the exudation circle, almost like a succinate, and the polyp sits right in the center. So these are actually, these images, to be honest with you, are in the these are the only old OCT machines that we had. We did not have the newer ones, which give you so much more delineation. So we were relying largely on ICG to pick up our polyps at that point of time and treat them with thermal laser. But we know from the Everest study that a combination treatment of PCV with PDT as well as anti-VEGF works the best. And here the anti-VEGF studied was Lucentis or ranibizumab. So combination therapy gave us almost an 80% resolution of polyps, vis-a-vis only 1/3 which showed regression when they were subjected to monotherapy with ranibizumab. So this is one of my very old examples where we had done a combination therapy, but once PDT was done, they usually used to remain recurrence-free for a very long period of time. That was the advantage of PDT. And sometimes we used to do anti-VEGF injection first because PDT had the inherent risk of causing a rip, especially in these very high PUDs. So this is how we used to calculate our GLD in cases of when we had to do PDT for ICG. So do you still need to do ICG if you want to plan PDT is a question which was again answered by the Asia Pacific Society of Imaging. So they gave these IR or NPAS OCT images to the graders, and they asked them to outline this area of suspected BNN and polyp as seen on IR image. IR image, I repeat, is very easily available alongside the OCT structural B scan image. And if you make a best fit circle around it, this should approximately give you a GLD. If at all you have a OCT-A as well, you can use that also to delineate your BNN, which will be very well seen. But we did have a planet study which said that you don't need to have PDT for all patients with PCV. They said that PDT at baseline is actually over treatment. So they have used PDT only as a rescue therapy. And in the planet study, almost 85% of the patients did not need PDT. And that is because they were using aflibercept. And aflibercept, we know, is a stronger molecule and has now have become the first line of action where PCV is concerned. Once you detect PCV, you are okay to start with aflibercept as a monotherapy loading dose. This shows a good response to aflibercept after multiple injections. Rolosozumab, the newer anti-VEGF, now not so new. And maybe Dr. Debdulal will talk better on this. And you can see very well the regression, even in the area of scarred area, that it regresses very nicely. You can see the multiple motion artifacts with this because it was a very vision, it was very low. But you can see that the PED has regressed so nicely, flattened with following rolosozumab. So what do you do once you have achieved some kind of regression or you have done the loading dose? You can do a fixed regimen, reactive or proactive, that is treat and extend. But treat and extend is one which is most commonly used. And the retreatment is if, depending upon OCT again, which is central retinal thickness, absence of IRF, and absence of subretinal fluid. Polypoidal lesion closure is a new endpoint actually. Earlier we used to believe that polyps may not respond to anti-VEGF, so you'd only look for these criteria. But now we also know that with the newer anti-VEGF, you could achieve polypoidal closure, and probably polypoidal closure is a better endpoint because it reduces the risk of recurrences and large submacular hemorrhages. So how do you ascertain some OCT biomarkers which show you the response? Look at this IRF, the subretinal fluid. This is the polypoidal lesion. So look at the height of the PED. Look at the sub-RP space. So here the sub-RP space is hyperreflective, which means it is active. Here it is hyperreflective, which means it is inactive. So presence of this hyperreflective ring, again, it increase in the reflectivity in the sub-RP space shows that you are beginning to get some kind of regression. So just to show you one or two examples, you can see here that this is a non-responder, that the height remains the same. And this is a good responder because you are seeing the flattening of PD, as well as you can see here it was hypoechoic, this area below the RPE, but here it is hyperechoic. So this is a good response. So based on this, a new treatment algorithm is there for the OCT. You can diagnose based on OCT or OCT-A. Start with initial therapy of monthly aflibercept injections, or if you want to go for a monotherapy with rolosozumab, after assessing the risk and benefit ratio. And here, then once the BCVA becomes better or the fluid or polyp activity is reduced, you could consider ICGA or go in for the OCT, OCTA parameters for responder or non-responder, which we just discussed. So if you think it is responding, continue with anti-VEGF, treat and extend. If you think response is not there, then you can decide on treatment to the polyps, which can be based on ICGA or OCTA, and add PDT here. But of course, we know PDT again has its issues. It's not available as freely as we would like it to be. So we are again ending up in doing aflibercept or rolosozumab, which in that case, we don't need ICG again. So the question is, do we need ICG at all? So there is a subset here, peripheral PCV, which I did talk about earlier, and then this is a newer entity, the peripheral exudative hemorrhagic chorioretinopathy, which is also got included in the pachychoroid spectrum. So here, when you see this massive hemorrhagic areas in the periphery, there would probably be an underlying PCV or polyps. So here in this area, as I said, we get the wide angle OCTA, which we don't have as of now. We need the wide angle ICG to look for these polypoidal lesions, because thermal laser to this lesion can be life-saving. Sometimes because of massive large amounts of hemorrhage, you are not able to do thermal laser, in which case you could resort to anti-VEGF therapy or a displacement of subretinal heme, which is showing you an example. This is the right eye of the patient, already scarred, large scar because of PCV. Left eye, he came with massive hemorrhage. And he did respond very well to 3 doses of aflibercept. He was lost to follow-up and came back with this again. Vision 160 now. So we have done a pneumatic displacement of the subretinal hemorrhage at this stage. And after that, you can see that the heme has all gone down with a small C3 effect bubble, which is present along with TPA intravitreally was given. But patient then had breakthrough hemorrhage, which is again also very common following this intravitreal injection, and for which we resorted to vitrectomy. Here, if you see, I have combined my TPA with anti-VEGF of bevacizumab and not aflibercept, because aflibercept is known to lyse. So if you give aflibercept along with TPA, TPA lyses aflibercept, and aflibercept loses its potentiality. So if you have to combine an anti-VEGF with TPA, go ahead with ranibizumab or bevacizumab, either one of the two. So that is all from me, and I'm looking forward to lots of questions and discussion and various inputs from my colleagues.
Thank you, Dr. Parveen Sen, ma'am. It was a very a wonderful talk on PCV. I'm sure must have cleared a lot of doubts most of us have regarding this slightly intriguing diagnosis and how to diagnose, how to go about after diagnosis. I would, the panelists can come into the discussion, and maybe we can have a discussion with our panelists, Dr. Ashish Sharma sir, Dr. Thirumalesh, and Dr. Debdulal sir, please.
I think Debdulal is the right person to talk about in the beginning.
Thank you, Ashish. Ma'am, it's always a pleasure listening to you, and I was really fortunate. Many of you might not be knowing, I was really fortunate to have ma'am as one of my mentors in SN during our fellowship, and she is one of those persons who's equally good in surgical retina and medical retina at the same time, which is probably a difficult thing to do, being among the best. So, ma'am, wonderful talk, and like I always learn from you, a few questions that often crop up in my mind when I see a patient of IPCV is the first one could be, something like sometimes I see a patient who like kind of identifies with PCV, but the other eye has drusen. So does the management strategy change in such a situation, or do you feel it's the same way that we go ahead?
So definitely, earlier we used to think that, as I said, when I was learning, we used to think that if it is drusen, then most likely it is AMD that you are dealing with, may not be PCV. But now we know that there is something called a drusen-driven PCV, which I did mention in my talk also, that these cases which have drusen-driven PCV actually have thinner choroids. They may not have thick choroids. And they have now been understood to have a genetic predisposition that the complement fixation factor as well as the ARMS2 gene may be more common in these cases. And here the manifestation is more like a type 1 CNV, and they are known to be better responders to anti-VEGF. So actually they may respond better to anti-VEGF. And now since PDT is not readily available, and better molecules of anti-VEGF are available, stronger, we are all starting PCV cases also with monotherapy. Here, I would say that you would still get a good response if you start as well as keep the patient on treat and extend regimen with anti-VEGF, you may not need to add PDT here. And because these are thinner choroids, you will also be worried about choroidal atrophy following PDT to some extent. I hope that answers your question.
Yeah,
so
thank you, ma'am.
monotherapy
Yeah.
is the way to go.
Ma'am, you showed one of those patients where which was a PEHCR patient and which rebled following her vanishing from your watch, if I may say so. In PEHCR cases, primarily you go with aflibercept, and so if there's a large hemorrhage and which you feel could do better with TPA plus a C3F8 or maybe SF6, then do we go back to a sort of maybe ranibizumab in such situations, or would you like to go?
No, actually, aflibercept itself, monotherapy is the drug of choice for PCV. Only ranibizumab or bevacizumab is to be done if you are doing it in combination with TPA. So if you are injecting TPA intravitreally, then this TPA is known to lyse or aflibercept. So the aflibercept molecule is amenable to degradation by TPA, but ranibizumab or bevacizumab molecule is not. So you can anyway want to combine anti-VEGF with TPA. So you could combine ranibizumab and bevacizumab, but that particular time you don't give aflibercept. But you could later follow it up with aflibercept or give it before that, you can do. So as long as the TPA is within the vitreous cavity, you are not giving aflibercept because it will be a waste. Patient will not get the benefit because aflibercept will not act. It will lose its potency in presence of TPA. But before that or after that, you can give. Yes, Dr. Ashish.
Do we have these sufficient evidences to prove that aflibercept is degraded because of TPA?
So there is a, I think, publication BGO which has mentioned it, and 2-3 other publications have followed. So I think this is now universally acceptable, and people who are using TPA in the subretinal space combine it with bevacizumab or ranibizumab. They usually don't combine it with aflibercept.
Is there any fundamental reason because of FC portion or something? Was there something mentioned?
Yes. So this is I think I showed it in one of my talks as well. So this is tissue plasminogen activator basically. So this causes lysis of aflibercept. So this is how it works. Because the aflibercept is lysed, the aflibercept molecule as such does not bind with the photoreceptor, the anti-VEGF photoreceptors which are present on the membrane. Because you need a configurational acceptance for them. That is what we have all seen, no? That the correct configuration has to be there for it to align with the. So that does not happen. So which is why this doesn't work well. So this is well accepted. I think the BGO is one where there is article this is described. It degrades the molecule.
Yeah, my question was because if bevacizumab acts, bevacizumab also is a full-length molecule, has FC
No,
portion.
I think it's not only, there is a difference in the molecule itself, no? The Fab and antibody portion and all may be getting lysed. So,
Thirumalesh, you have any point? You track my biomarkers quite,
yeah, Razubap works. You can try that. You can any ranibizumab. I did not say only eccentrics. Any ranibizumab, biosimilar of ranibizumab will work. Biosimilar of bevacizumab will work.
You said bevacizumab would also work. Is that right?
Yes.
And that's where
inherent to the to aflibercept molecule that it does not.
No, aflibercept actually, like Madam said, is a fusional protein. So tissue plasmin activator has this effect of cleaving the protein. That's why it doesn't go and bind to the R1 or R2 if you use along with the TPA. The other two are actually antibodies. So they tend to bind with the VEGF. So that's the basis of how those authors say that if you use a fusional protein along with that, it cleaves the fusional protein.
It cleaves
so the protein undergoes a conformational change. So then it does not tend to produce the intended activity. Biomarker wise, what you are asking, if we have studied aqueous biomarkers of patient across, both the ones who are having only AMD kind of a phenotype and the patients who are having a PCV kind of a phenotype. The difference in biomarkers is not, any different. It depends upon the stage of the disease at which we are studying the biomarkers. So we studied about 18 biomarkers from the aqueous, which we were looking at. But there is no consistent variant. If I give you a biomarker from the aqueous, where we have listed them, and if you look at the ones from CNVM and the ones from PCV, the difference is not very huge, which means that inherently the molecular crosstalk that is happening is very similar. But PCV is a disease where there is a structural flow difference. So that's why the papers from Spade makes such a large difference in understanding the concept, that once people used to think that if there is a CNVM, there should be just a membrane. If you say pachychoroid, there is dilatation of the choroid with formation of polyps. But when you say IPCV, you are basically thinking of an age-related like process, but with an associated flow abnormality. So that's why that occlusion of large choroidal vessels and those tend to make more of sense. That's why majority of the markers now that you see on OCT also shows these double membrane sign, peak PAD. These are all flow-related disturbances. The formation of the membrane is a heralding sign which says that there is induced choroidal ischemia, which produces the neovascularization.
So initially, some studies were done, and they have mentioned that the levels of VEGF in a PCV would be lesser as compared to the levels of VEGF in AMD, which is why it was considered that it is less responsive to anti-VEGF therapy as compared to AMD. So again, but the real underlying cause of why it shifts to PCV and not AMD, we don't know. But anoxia, as we just discussed, that is because of the hallus layer. The choroid is thickened, but the choriocapillaries, which is the source of blood supply to the RPE and retina, that gets pushed and squeezed. So that causes hypoxia, which triggers neovascularization.
That's absolutely well taken point.
Again, for all you know, you may end up doing surgery for PCV also, because it is said that it is the vortex vein congestion which causes it. So maybe if you release the congestion, you may actually release the symptoms of anoxia also. So we don't know. The jury is still out there open, which is why now the spectrum of CSC is going into uveal effusion and all that. It's becoming difficult to differentiate all these things.
It is more of a chronic kind of a process. It's not that, if you are talking about mechanical relieving of pressure, like what Spade's group mentions, that, if you release, it becomes okay, that you have to do at the point of onset. By then the patient wouldn't have even presented to us. So this is more of a chronic process that tends to kind of present to us. By the time we look at it, probably that point is already, gone forward, but it is definitely part of the pathogenic mechanism. What I was talking about was that when we look at the biomarkers of, patients who had these sub-RPE membranes, or when there are large PEDs, the VEGF levels kind of is high in that. And if you look at the phenotypic part of the patients who are having PCV, it kind of matches with that. But to actually say whether based on biomarkers we can make a difference, it's a little difficult to say, because it's not just the polyp that is producing the problem, but it's also the hypoxia that the RPE is suffering because of the choriocapillary attenuation, and how much is the area that is suffering this problem. That would probably yield how much hypoxia is there and how much VEGF levels are being produced.
Means even the Spade concept, if you see his paper, means on where he has written a big lengthy paper to explain the vortex vein hypothesis. If you really see, means that's a part of almost 50% of the normal population as well. So if you cannot really say and decide your treatment based on that. So means the theory exists as a existing pipe, resistor of the pipe, but it still means a lot of normal population lies in that particular spectrum as well. So any of you means using brolucizumab as first line agent, Debdulal? I think, for these
Yeah.
patients?
Yeah, I think we've been using brolucizumab for a while now, and we've used it with TPA, without TPA, and what we've realized is that like uh, given the nature of action of brolucizumab, many of the patients who initially I would be really inclined to use TPA might in fact do well without TPA. But having said that, then brolucizumab comes with its own baggage, and that is something that has to be explained to the patient. Yes, we do use a lot of brolucizumab, and a lot of the patients coming in from the government health schemes in West Bengal, they actually get brolucizumab as first line. So that also makes this first line treatment for many of the patients with PCV. So as far as the regression of PEDs and membranes, the BNNs that we've looked into is maybe better than what we have been achieving with other monotherapy as of now. But I think the jury is still out on that also.
Did you see the differential impact on the large PEDs in these cases with these two agents?
Absolutely.
Yeah.
I think there's been a lot of change from ranibizumab to aflibercept and brolucizumab. I think the PEDs, as far as the PEDs go, brolucizumab is likely to flatten them out the best, followed by maybe aflibercept. But having said that, I think you have a quarter of these patients who also respond to ranibizumab, like patients who can't take brolucizumab or do not want to take brolucizumab or aflibercept for whatever be the reason. I've seen a lot of patients who with maybe I can definitely remember people with hemorrhagic types, or maybe even the exudative, or maybe some of the mixed types, which are not really the really bad ones. Maybe they have done really well with a loading dose of ranibizumab with or without C3F8, maybe in certain situations, and they really do well. I mean, like some of them. But having said that, of course, the first choice probably is aflibercept for me, followed by brolucizumab, then maybe the other agents. Ma'am, can I ask, kind of little go back from management to diagnosis? Do you have a thumb rule of advising ICG in some, like we have the major and minor criteria for SDOCT now? So where would you be inclined to, really ask for an ICG?
So I definitely now feel lot of the time you can diagnose PCV on OCT. So we have seen so many cases now that it is OCT diagnosis. It's not that it cannot be diagnosed. And if I were to do PDT or thermal laser, if I think there is a point where I could do thermal laser, then I would definitely want to do PCV to ICG to begin with. But as I said, since PDT is not available, and if most of my lesion is subfoveal, I do not achieve anything by doing additional ICG. So in those cases, I may not really want to do. So at this point of time, with non-availability of PDT, only indication to do ICG would be to look for extrafoveal polyps, which can be treated by thermal laser, because that definitely will bring down the number of injections which you would need to give. All said and done, the first result of the Everest study was that it is the polyps which are resistant to anti-VEGF treatment. In fact, when we started doing PDT for PCV, we were never aiming to cover the whole complex. We always used to treat the polyps only with PDT and not cover the BNN. Probably BNN we were not seeing then because OCTA was not there, and ICG would show us some kind of a plaque. So the indication was to treat polyps with the PDT, not the plaque, the whole thing. There were two schools of thought. One used to say that you should treat the whole complex, and the other was that you could treat only the polyps because that could keep the complications of PDT to a minimum. So if you are not doing PDT, and if you think there are no extrafoveal polyps, then definitely you could avoid ICG.
Ma'am,
I have a question here, Dr. Debdulal sir and Dr. Ashish Sharma sir. We discussed about the role of brolucizumab for PCVs, and you said that brolucizumab has effect but comes with its baggage. The baggage we are talking about is actually real. We have heard about inflammation through brolucizumab multiple places. Even I have seen that, so it's not unreal. The baggage that brolucizumab comes up with. If you say we discuss this with the patient, are patients going to agree when we is there any particular set of patients of PCV where we would like to be skeptical about using brolucizumab, or the baggage that we are talking about can arise for any odd patient? If that is actually a scenario which is not a very unreal situation, which probably is not there with any other of the anti-VEGF, including bevacizumab and not so much even with the bevacizumab biosimilars, but the baggage we talk about is brolucizumab is real. So if we discuss this with the patient, are any of the patients actually in real world situation going to be willing? And then which patients, is there any way to be skeptical about what patient can have an untoward reaction to brolucizumab if we plan so, or it can just be a random any odd patient can have this baggage?
So what is tried, everybody tried to find the risk factors, which could lead to these kind of adverse events with brolucizumab, but there was no consensus. We could not find real risk factors here where you can find, this I should avoid. So everybody tried. Latest paper also, they tried to find out, but there is no algorithm. Initially, we published a paper, how to filter some patients, but so you can filter females, you can filter patients who had previous inflammation, but nothing was proved actually. So you cannot really pinpoint that, is in such particular patient, I can avoid it. So means in my practice means we did a lot of work on brolucizumab. Means I was quite excited with that molecule since it started. But over the time, when you have the 4% of adverse event, then whosoever would land up in what? The problem is, even if you look at the Hawk and Harrier data, why it did not show what was shown later? Because as a clinical trial, whenever we participate, we do not see periphery. Means we, as a clinical trial, we do interact, but nobody sees the periphery. So a lot of occlusions were happening on the periphery. So that's where things were detected. So even in now, the practice, we do not know in what number of cases periphery is getting compromised. So means it's very difficult to really pinpoint that which patients you can safely inject. Means my usage has really gone down, and I, once I get tired of aflibercept, and once I then I give an option, this is something is there. Means a lot of Indian scenario is people have not seen that things can be manageable, but not to start with in any of the case.
Similar would be my experience with brolucizumab. I used in a lot of patients, but my usage has gone down because of some of the adverse reactions which were completely unexplained for in some of the patients, and then it becomes a difficult situation. And why to get into a trouble of putting a confusion of one more molecule to the patient? Why to do that? Why to do that if there are safer molecules?
I think it's because my usage has gone down, so my experience is not enough to really tell something. Probably Debdulal has richest experience in real world, using this molecule. So probably he can have a more say, realistic say towards it.
I think, thanks Ashish for the compliment, but I think, I should, what I should mention here is that like Disha probably sees a lot of patients, and we are 22, 24 of us retina guys in Disha. And so, I am speaking for all of them. So basically, what actually happens when we offer a basket choice of anti-VEGFs to all patients, and do mention like in situations such as PCV that probably these two are the drugs to best suited for your disease. But having said that, again, like Shishir was just mentioning, we do mention that this is likely to have IOI. But the interesting catch here is that some of the patients from the government health schemes do not like really think back, and they get the brolucizumab easily from the government sources, and they come back with that in hand, and we give the injection. What we've realized over time is that with us in Disha, following don't give injections of brolucizumab to, like, patients with arthritis and stuff like that, severe cardiovascular ailments and all. But we've still had something like 1.5 to 2% of IOIs. Thankfully, all of them have been none of the patients as of now have really lost vision. We really have had just one case of arterial occlusion, and that too in a peripheral arteriole, and that has been pretty lucky for us. And almost all of these patients have responded to topical and or oral steroids, and we really haven't had the opportunity to, or touch wood, thankfully, to go in with an invasive procedure or maybe even an intravitreal dexamethasone. So that's on the one side. The other thing is, it's absolutely unpredictable when these will, IOI happens, as we all have read. And we've had patients who've had, events after the first, which is around 15 to 20% of the cases. And usually they occur at around 3-4 weeks after the first. So you can call the patients back maybe a 3-4 weeks time, but it's very difficult to keep them calling back. And we've had events after, maybe around 2 months time. We've had events at 3 months. We've had, IUIs even later with maybe 6th, 7th injection or thereabouts. And we've had patients with maybe 10, 12 injections of brolucizumab who haven't had any issues. So it's really a difficult, thing to answer, like Dr. Ashish just mentioned. So really difficult, and it's best for the patient to kind of, sort of understand and then decide whether he or she is still going to go ahead with that particular drug, or would like to, go ahead with aflibercept maybe.
But
Parveen, your
definitely
experience?
the efficacy of brolucizumab is unquestionable. So it really is a very efficacious molecule. That is definitely there. IOIs were really unfortunate, because I have seen in the few cases that I've used, the flattening of PEDs is amazing. And you can easily straight away go to a PRN. I mean, you need not really do a loading dose of brolucizumab also. So one injection, usually 2-3 months, you can, give a gap of 2-3 months before you give the other injection. Only unfortunate thing is, you never know whether 6th or 7th injection may cause the problem. But efficacy wise, it is very, very efficacious molecule.
Yeah, Thirumalesh sir, please.
Yeah. So with reference to brolucizumab, even I used to use brolucizumab as first line for quite some time. But recently I had 2 patients who came with intraocular inflammation, although it was not, very bad like other people also have seen. It was a peripheral occlusion. The patient got off very easy. So ever since I saw those 2 in practice, where I had a little tachycardia after seeing the patient. So now I really don't use brolucizumab as the first line. Now I'm kind of more in favor of doing aflibercept, and probably in those patients where aflibercept is not working well, then I switch to broli. And second thing I actually wanted to tell you guys was that PCV is something that I have self-learned. During residency days, the amount of teaching that used to happen with reference to diagnosis of PCV and confidence to diagnose PCV based on OCT. For a pretty long time, I always used to think that to diagnose a case of polyp, you should actually do a ICG, and there is no other way of doing it. But then I kind of started reading the articles, but the way the confidence of doing a diagnosis of a polyp on the OCT was not that much. But I think today Madam differentiated and showed so many slides where all those classic signs were very clearly delineated and differentiated. I think you guys at ASD should share this video with us so that we can keep this as a guide whenever we have doubts of making a diagnosis of polyp on the OCT.
For sure, sir. I have one question for Parveen ma'am. Ma'am, in the presentation, you had mentioned that asymptomatic PCV patients we can still observe. But in a scenario wherein one eye has been lost because of a disciform scar because of ignored PCV, and the other eye, the patient presents with a quiescent PCV where there is only PED or a double layer sign, no SRF also. So does that scenario change our management in somehow?
So actually, if you have a polyp, it is a given that double layer sign has to be there. There must be a BNN, there has to be a network, then only there is a dilatation. So if there is no SRF and no IRC, it is almost like a non-exudative CNV kind of a picture. And in those cases also, since we still don't have an end point of treatment in these eyes, how do you start treatment then? Your treatment follow-up is based on presence of reduction of SRF, reduction of IRC. If you don't have that to begin with, and you ultimately, how many injections will you give to achieve polyp closure is a doubt. And the kind of picture which I showed you, which had a central network and all around surrounding dilatation, that patient may take 50 injections for each polyp to close, and vision is 6.5. So you really have to think the rationale of therapy. That's all that is saying. In the absence of SRF and IRC, if you have a polyp, most likely the vision is going to be 6.5. So you really best is to, and if it is single-eyed again, you will be even more worried to start therapy. Because in most of these cases, we don't know what is the end point of our treatment. If that is the practical kind of a thing. So better is to, if we have a better treatment which can obliterate the CNV and polyp altogether, then it is great.
So treating on the basis of, let's say, an Opta or ICG based regression of polyps is not a good idea per se. Until the patient is.
Better is to look for biomarkers like IRC. First, you have to establish activity, that they are active, they are causing SRF, they are causing IRC, then only, and their patient is symptomatic. No fluid, no IRC, and no symptoms. It's an incidental finding then you are not justified in treatment.
Sure.
Sub-RP has been proved that you can literally wait and watch. As Dr. Parveen said, watch for the real sign of activity. Sub-RP also you can watch closely. Even that sometimes if goes up means I take my decision based on that. If anything goes up, even sub-RP, although it's a little protective for the lesion, but still, if that also goes up, I inject.
So somebody has written that this risk of bleed is very high when even the OCT is dry. So I 100% agree. But what is the treatment? What would you do? That is something you have to weigh the risk and benefit ratio. Of course, the patient is sitting on a bombshell. It may massively bleed and the next day the patient may become NPL. So that is something which you have to.
Hemorrhagic PEDs in the mid periphery.
Yes.
And the patient's vision is 6.6.
Yeah. So those cases you have to treat. Then you treat because subretinal bleed is there. That is sign of activity. And whenever you treat those large hemorrhagic PEDs, whether they are in the periphery and especially if they are in the periphery and vision is 6.6, you still must explain that anytime this risk of massive bleed and NPL is positive, and if the patient is associated having high blood pressure, please keep a note that high blood pressure has to be kept under real good control. Otherwise, this can multiply the risk of massive bleed. And I have seen a patient of PCV which bled in all possible layers. So intravitreal, subretinal, sub-RP, suprachoroidal, massive hemorrhagic choroidals as well with PCV. So it can really have.
No, actually, somebody asked a question that, if you just have a polyp and the vision is 6.6, and we are treating till, the polyp closure happens. So I used to believe in this concept that, in polyps, we are treating to prevent the subretinal bleed. But like Dr. Parveen said, sometimes you might give the injection, the patient is actually sitting on a bombshell. And this happened with me, that I did a ICGA in a polyp which has a nodule. There was no fluid anywhere. The only finding that I had was a polyp on the ICGA. Vision was 6.6. So I explained the patient that, the philosophy of treatment in polyps is that, you prevent a massive subretinal bleed, which can make you blind. And to my bad luck, I injected, and 48 hours later, the patient developed a bleed. It's not that it is going to cause regression immediately if you start treating, it can also happen that
He
while
should
on the
not-
course of treatment, it can still bleed. So like she said, identify the end point that, although you tell them that you are going to probably make them better by giving the injection, and there is a good 70% chance of polyp regression. But in a patient where the vision is very good, you keep a good watch. And second important thing is majority of the patients who have bleeds, if you check their blood pressure, I mean, we have this habit of checking blood pressure on the day of injections. And I have seen patients who came for diagnosis during the ICGA, their blood pressure was about 150/80, but on the day of injection, the blood pressure can go as high as 200. So it's not just the polyp, it's like having an aneurysm in the brain. It would not have bled, but sometimes even the pressure of that injection, that on the day when he came, that pulsatile increase in blood pressure, that itself might also be happening at home as well, isn't it? So that also is a risk factor that can cause a bleed. So we cannot really take care and cover all the bases saying that this is how you're going to treat. But with the risk benefit ratio, you also have ENDOF to consider. You also have intraocular inflammations to consider when you're giving agents like brolucizumab. So it's a well thought out process of about what you're considering, and have the chat with the patient and then take a combined call so that the patient doesn't blame you at a later date.
True, sir. Sir, coming back to that PEHCR, there are some cases of PEHCR which present with exudative RD, and those exudations are like massive exudations. So how do we go about in such patients? Because giving an injection is, I think, the only possible option that is left, because the temporal areas of hemorrhagic PEDs they get covered by the exudative RD itself. So going ahead and doing a laser over there is as such not possible. So any other thing that can be tried in such patients who present? I had a case of bilateral exudative RD because of PEHCR. One eye responded well. I had given aflibercept. One eye responded well after the first injection itself. The next eye, even after 3 injections of aflibercept, did not respond at all. After the 4th and the 5th, eventually the SRF came down, and once the retina settled, below the retina there was a sheet of exudates. So in this eye, the vision did not improve even after resolution of the SRF, because there were deposits of exudates in the subfoveal region because of long-standing SRF. Anything else I could have done in such cases to fasten the recovery per se?
PHCR, you always have an option of doing a cryo right in the beginning, the moment you make a diagnosis. So that's why if you have a Heidelberg, you also have that attachment where you can take a wide field ICGA. So make it a habit that you take a wide field ICGA in every single patient. So I usually do that for even my diabetic patients where I do an FA. If I have a CNVM patient and I'm doing a combined FA plus ICGA, I make sure that I have taken a wide field. So in patients whom you are suspecting polyps, and it's always a good idea to look at the wide field image as well. If you find a polyp in the periphery which is asymptomatic as well, you can take up the patient for either laser or a cryo. I mean, depending upon what you're comfortable with, and if you can do a laser in the periphery, excellent. Otherwise, you can use a cryo as well.
Would cryo increase the exudation further? Is there a possibility of the cryo leading to more?
It's only, I think, temporarily it will do,
Yeah.
but that will. And the other thing is, these are the cases which are the ones where you have to do your heroic surgeries then. So
Yes.
here you have to do vitrectomy, you have to do RR, you have to remove the subretinal bleed, and I think go back to laser and then put the patient with oil. So this is, you are going to have scars anyway in the macular area, but at least to give some kind of ambulatory vision. These are the cases which need subretinal or surgical heroic surgeries. You do RRs and reflect the retina and remove the whole subretinal blood, and then put it back, do laser, leave the patient with oil. You could use that cocktail of, in a smaller bleeds, a cocktail of TPA plus air plus bevacizumab. That has also been described. So you use 0.1 or 0.2 ml of TPA.
Talking about, ma'am, here the TPA is intravitreal.
No, this is a cocktail of subretinal, TPA, air, and bevacizumab. That has also been
This has
tried.
to be combined along with vitrectomy or
Combined along with subretinal, how you will give it away. So vitrectomy with PVD induction. Then you take this in that 40 gauge submacular set you have, which gives you 1 ml syringe onto a 40 gauge extendable needle. And in that syringe, you take about say 0.1 or 0.2 ml of TPA. Then you, along with it, you take about 0.2 to 0.3 ml of gas, air, only air, not gas. And you could combine it with the 0.05 or 0.1 ml of trevacizumab. And this, then you, with a slow injection, you give it in the subretinal space. The air is supposed to agitate the blood. TPA then lyses it, and bevacizumab does the job of anti-VEGF. And here they have very smartly also done, followed up by a partial fluid gas exchange, so that the SF6 remains in the upper retina, where the blood doesn't come, and the blood then moves or displaces all down. This has been, I think, widely described in a lot of talks by Dr. Atul as well. He has also given a lot of talks and is described in literature also. It has been used and can work. Otherwise, simpler thing is the subretinal TPA with the anti-VEGF also works. You need not give air, because sometimes giving the air may increase the complication rate, but it has been used with the, without, in good hands, it has been used also. So it's good to know.
Any benefit if it is not, if the bleed, a complicated PCV has not a massive subretinal bleed, there is a bleed localized to the macular area probably, where we are not planning a radical surgical approach. We are only planning pneumatic displacement of the.
Yeah, you can do that.
So there
That
is
is
a
also
role of an intravitreal TPA. Does it
yes,
have
yes, yes. Intravitreal TPA with intravitreal anti-VEGF and intravitreal C3A8, 0.3 ml, 0.2 ml also you can use, so that it's a partial bubble. It doesn't get superiorly displaced. You can do that. In fact, the case which I had shown, I had done that only.
Going back to Devashish's, like, exudative, where you have PHCR with lot of subretinal bleed, and like, these patients actually, what ma'am was mentioning, if you go in, do a RR and remove the subretinal blood, many of these patients actually go on to do really well, especially in PHCR. So maybe, and I mean, you can try out. And unlike PCV per se, where most of the patients have a bad scar in the macula, they remain at 360 or maybe 160 post surgery also. But in PHCR with massive subretinal bleeds, I've really had some wonderful experiences, and the patients are also happy. So you can also maybe think of those lines.
That I was mentioning about, he did not have a bleed. He just had exudative RT serous. So that is why I did not plan to do surgery, because I was expecting once the fluid resolves, the vision should improve, because there is no blood component there. But still, some amount of exudation did deposit subretinally, and I think that is the reason which caused the loss. But as you're saying, maybe in such cases also, maybe intervening slightly early might have changed the final outcome.
Ma'am, I'd like to know from you, like, I've had a couple of patients with maybe around 3 months of exudation in similar situations what Devashish has just mentioned, and I have drained, like, done a vitrectomy and put in oil, and they've sort of had maybe 660, 636 vision, 2 of them. So would you recommend doing a vitrectomy in non-resolving exudative RDs in such similar situations?
I think any non-resolving exudative RD needs surgical intervention. So I think this is no different, and especially this one, because we know that risk of massive hemorrhage is always there. But exudative RDs, if they are not resolving, especially even inflammatory ones, they are prone to develop retinoretinal adhesions. So in which case scenario, if you want to prevent that, I think you may consider, and obviously vision does not improve. So surgical intervention does have a role.
Do you have a cutoff time when to, like, surgically intervene?
So it depends upon the treating doctor. If you have treated fully, completely with systemic steroids, especially with inflammatory, and still patient is on maximal steroids. So sometimes I remember I had a case, patient was on maximal steroids and then started developing secondary glaucoma because of that. This was a case of VKH. And then went on to develop retinoretinal lesion. So once I could see that the retina is sticking because of the inflammation and because it was a young patient, so there was no PVD also. So I had to resort to surgical intervention. So that depends. Usually, if you have tried immunosuppressive also, you have tried steroids also, and you don't see a response. I think this is more of a clinical judgment rather than a fixed time period. It may vary from patient to patient, from disease entity to disease entity.
Right.
I had a interesting experience where I was treating a patient for the submacular bleed. So the bleed was not too large. So I thought, let me see if I can displace it. And, I gave an intravitreal injection with gas. I found that the clot was pretty solid. It was not moving. It was like organized fibrin. When the patient came to me, we discussed that, can anything be done about it? And this patient I had already given 3 injections. And I did a surgery in that particular patient where I did a vitrectomy and injected subretinal TPA with Avastin. The clot kind of did not go away in the immediate follow-up. But by the time he came on his 3rd follow-up, the clot kind of completely resolved. And his presenting vision and immediate surgical post-op vision was very stagnant at 636 for quite some time. But when the patient came for a follow-up after about 8 months, he did show good improvement of vision. And surprisingly, when I saw it, I saw that although the fovea had the problem, the perifoveal retina was pretty much healthy, and that was the reason why after disappearance of the clot, he did have some kind of vision. So what I'm trying to say is that sometimes even intervening a little late, where you can give subretinal TPA with anti-VEGF injections, probably can help in a few patients.
Something is better than nothing. Here you are trying to just save some kind of ambulatory vision. The idea is not to get 6/6 vision here.
We'll take a couple of questions from the chat box. And Dr. Trisha has asked, what would be the specifications for thermal laser for extrafoveal polyps? I feel she wants to ask the parameters that we can use for thermal laser in such polyps.
So I think the traditional setting is what I use for CNVMs. The traditional setting for CNVM usually is a spot size of 200 and the duration of 200. Don't use very small spot size and small duration because that can cause risk of bleed. And again, power, slowly increase the power as to, you could use it in a separate extra away from the lesion, you can try and then come back. So just like you would treat a CNVM, I think that is how you need to treat a polyp. First you do the boundaries and you cover up the whole polyp in the center as well with the laser.
Sure. Another small interesting case scenario that I encountered was there was a gentleman who had a PCV with the SRF. The vision was around 618. So I treated the patient with the aflibercept injections. So after giving 3 injections, the subfoveal fluid resolved. The vision improved from 618 to 69. The patient was quite happy. Once I dilated him and saw there was a RP rip with a subretinal hemorrhage. The hemorrhage was just above the fovea in the superior quadrant. So to my horror, I thought that the hemorrhage has happened. The patient was very happy that his vision has recovered. In such a scenario, I did not want to go ahead with a pneumatic displacement also because it was in the superior quadrant. So if I would have done something like that, the blood would have trickled and come subfoveally. So I went ahead with giving in some time I went into giving another injection of aflibercept to see if that could help. But anything else from your side that we could have done in order to manage this case in a different way?
So this is something, is not a very uncommon thing. It can happen. So here, one option is to observe. Second, there have been publications where they say that after the rip has happened, usually a second rip will not happen because already it has kind of relaxed. Now, if you think your lesion is active, you could still treat. In your case, you could have switched from aflibercept to ranibizumab. It's a slightly less potent to further cause any issues. And if there was any activity, it could have dried up, or you could have increased the treatment interval. It's not to do anything, but let the patient come back since he was already 6'6". Patient is happy. Tell him that this issue is there. Let him be happy for a while. If something again activity is there, then you can consider treating with either ranibizumab or aflibercept. But preferably, you could go to a milder anti-VEGF for a while to maintain 6'6", and let the scarring happen, and then go back to aflibercept if ranibizumab is not working.
So, ma'am, like different anti-VEGFs have different propensity to cause a rip, as in.
Yes.
Usually
So, yeah, aflibercept more potent, brolucizumab even more potent. I think it has been reported to cause increased risks of rip. So the thing which causes rip is a sudden shrinkage. So that sudden shrinkage will happen if the height of PED is more or the potency of the drug is more. So these are few risk factors, or if it is very tense. Sometimes if you see very tense PEDs in a patient of PCV, that is one case where I may start with ranibizumab, let it become a little response, flatten out a little bit, and then go to aflibercept to prevent rip.
Sure. Dr. Ashish sir, in your experience with biosimilars and PCV, anything different from the regular anti-VEGFs?
No, it's same as Lucentis.
I'm waiting for the aflibercept biosimilar. So then.
Yeah.
Thirumalesh sir.
So I have a question. The patient that I said that I treated with subretinal surgery, it's a proven case of PCV. The other eye, I have an ICG where there is no polyp, but he had a small neurosensory detachment at the fovea, which I've been following up for quite some time. I did an octa. There is no membrane in that. But do we treat the patient by giving an intra?
Yes. Subfoveal polyp without BNN. Sometimes you do see maybe BNN is not visible, but subfoveal polyp is an entity which is really difficult to treat because they are usually large polyps, and they have the risk of causing permanent damage. There will be exudative variety with the exudates coming and settling down onto the fovea. So please treat.
No, this patient actually is between me and Dr. Gopal Pillai because he treats the patient in Kerala and I treat whenever he comes back to me in Bangalore. So I have given one injection. 2 months later, he went back to Dr. Gopal. He also has given an injection. There's no polyp per se. There's no membrane in this particular patient, but the NSD is not budging to 4 injections.
Why the NSD then?
No idea, ma'am.
No polyp, no BNN.
I have done. I will share the ICGA in the group that that these people have created. That patient has no membrane. The patient does not have any polyp, but he has a neurosensory detachment. And the only thing that you can see is the choroid is thickened and there is choriocapillary attenuation. Apart from that, he does not have anything.
You can have CSC in one eye and PCV in the other eye. So please rule out that. Maybe you can do an FFA to see if there is a smokestack.
It's a combined FA plus ICG, but I found no leak in that. So this is one thing that's been.
This can happen. So you may have one spectrum of pachychoroid disease in one eye and the other in the other eye. So
this could be the artificial space. This could be the artificial space without non-exudative, non-miss because there is an entity.
This is something which you have, artificial space. You see it above the
dome shape
PEDs or something like that.
Okay.
Yeah.
So
but
tomorrow
he said it is NSD.
Yeah, tomorrow I'll send the both ICGA and OCT of the patient. So I would want you guys to have a look at it and let me know what do you think.
Sure. Interesting.
Another thing, ma'am, was once after the anti-VEGF, once the regression of the polyp happens, and if the recurrence happens later on, does the recurrence of the same polyp happen, or is it a new place in the BVN where a fresh polyp reappears or appears?
Both the things can happen. You could have new polyps, or you could have recurrence, which is sometimes known to happen after 2-3 years also. Especially after PDT, when you have achieved closure, So, which is why long-term follow-up of these patients is important. That is why it doesn't behave like AMD. Though initially the vision may be better than AMD, but they may end up finally having vision which is worse because recurrence rates are high.
Sure.
Yeah. I think most of the questions have been taken. Devashish, I
Yeah,
think
most
we
of the
can
questions
close.
have been answered by Dr. Ashish sir in the chat box itself. I'm just trying to find anyone which has not been answered.
I want to ask a question regarding brother. I have had a strange ways of getting inflammation in to patients who've been injected brother. We had a patient, one-eyed patient, unfortunately. The other eye had complicated cataract surgery, which underwent a DSEC, improved vision. Then eventually that I had PCV, which was treated with injections, but eventually it scarred. So one eye that eye was lost. The other eye was in follow-up with us for some time. The vision was stable 6/6, and eventually she developed a PCV in this eye. We started treatment with ranibizumab, switched to aflibercept. We injected her around 5 or 6 aflibercept. She was maintaining 624, 636. Initially, before the PCV, her vision was 6/6. After developing PCV, she improved to aflibercept, but her vision had eventually dropped to 624, 636. She was in that range. So after 5 or 6 aflibercept, she was not very not having much subjective improvement to injections whenever she had fluid. The fluid would subside, the PCV would regress, but she was not very comfortable with the vision. Subjectively, she was not improving. So eventually, she took multiple opinions, but she got the same answer that the injections would be the way out. So we switched to brolucizumab. Again, with brolucizumab also, she did not have much subjective improvement. But after 4 weeks, she was also on anti-glaucoma by glaucoma specialist. After 4 weeks of this only brolucizumab injection, she had a drop in vision to 1/60. Her IOP was around 50. She had reaction in anterior chamber, and we thought of this as an inflammatory glaucoma. And she was already one-eyed. We treated this with steroids, topical, oral, and anti-glaucoma medications. This acute reaction subsided, which developed 4 weeks after brolucizumab. And she again went back to her vision of 624, 636. But I think any such insult will always have some long-lasting detrimental effect on the vision. She feels her vision is the same 624 is not as good as it was earlier before this episode. So has anyone had this kind of, there's no vasculitis-like activity in the retina. There's no occlusion in the retina, but this reaction happened 3 weeks or 4 weeks after brolucizumab, where she had AC reaction and her IOP had shot to around 50 or 60, which subsided. So anyone with such a adverse reaction post brolucizumab.
Yes,
So
I've had two such patients, and like you mentioned, in one patient, the patient had a reaction like at around 2 months following the brolucizumab injection. We were on a PRN. I am always on PRN for brolucizumab for my patients, and patient came back around 2 months later with blurred vision, and I could see there were lots of KPs, and there was anterior chamber inflammation, like you mentioned. The fundus, the peripheral fundus also looked good. We did an optos also for this patient and followed up with 3-4 more optos examinations just in case we missed anything on clinical examination. And we basically put him on topical steroids, anti-glaucoma medication, initially Diamox also, acetazolamide orally, and in a week's time, IOP was initially 48, dropped down to around in the mid-20s, and then down to 15, 16, and that's how the patient has been. We've re-injected this patient with ranibizumab subsequently, and the patient hasn't had any issue. But like you mentioned, there's some disc pallor that has happened, and vision is 6/6 in this patient. But like you mentioned, the patient has some difficulty in the contrast. So that's happened. The other patient also similar story. raised IOP, coming back down with topical medication and initial acetazolamide. So I think this is something that actually has to be on the back of everyone's mind when we use bevacizumab also. I mean, like IOP, raised IOP also.
Thank you, sir.
Thank you, sir. I think all the questions have been taken and answered from the chat box. I would just like to conclude the meeting and say that it was such a spectacular and enlightening meeting that took place right now, with such distilled and knowledge from the veterans of our field. So I would again want to thank Dr. Parveen Sen ma'am for such an amazing lecture. It was extremely enlightening for all of us. And also our panelists, Dr. Thirumalesh sir, Dr. Ashish sir, and Dr. Debdulal, for their expert comments and so much knowledge that they shared with us. So
thank you, ASG team, for inviting me here. It's always a pleasure to interact with you all, and I always learn whenever I have a talk. So thanks for making me learn.
Yeah, thank you, ASG. And it was a superb masterclass. I mean, a lot of my OCT concepts were very clear, and thank you, Dr. Parveen Sen, for making it such a wonderful class.
Yeah, thanks from my side. Thank you, ma'am, and everyone at ASG. Thanks, Dr. Thirumalesh and Dr. Ashish. Dr. Atul, thanks a lot. Take care. Stay good.
See you in the next meeting. Bye-bye. Bye.
Thank you.
Thank you, everyone.
Thank you, everyone. Thank you.